Hi, Gabby. Hi, Sarah. Welcome to the forum. Thank you so much for volunteering to speak this week. Very, very much appreciated. Gabby and Sarah have both undertaken PhD projects at the University of Cambridge in the radiology department. Gabby has completed her PhD. She did a successful examination and has handed in her thesis and is now working here with us in radiology as a postdoc. Gabby's a scientist by background. She came from a positron emission tomography background and then did her MRI in breast MRI, focusing on diffusion weighted imaging, and is now doing AI and some radiomics, and she's going to talk to us about that. But first of all, we're going to start with Sarah Hickman. Sarah's a junior doctor who elected to do a PhD. She did her she followed an academic pathway when she graduated. And after 2 years, she did a placement in radiology and then joined my group as part of my CERA UK programme grant. And Sarah's going to apply to do radiology. I think she's known to many of you in the radiology department already, and possibly you can guess her relationship by her surname to one of our excellent radiology trainees. So Sarah's going to start the forum this week. Sarah's working on my CERA UK programme grant, where we're looking at early detection of breast cancer. Part of the programme grant is the Big Braid trial, which is looking at women with dense breasts and looking at which other imaging modality, which supplemental imaging modality they should have. But what Sarah's been focusing on is whether artificial intelligence can actually help us improve our performance in the breast screening programme. And what she's done is she's worked amazingly hard to create a very large cohort of patients from the breast screening programme based from Cambridge and also now from Norwich. And what I'm going to do is let her explain to you what she's been doing with her PhD and how she's gone about setting up this pipeline of research, how she's set up the database and got permissions, and then what she's been doing in testing artificial intelligence algorithms. So Sarah, I'm going to hand over to you. Thank you so much to both you and Gabby. I think you're going to do about 20 minutes each, is that right? Okay, great. Thank you so much for doing this for us. And I think you'll see that people will be joining us as we're doing. It's mainly, well, it's a mixture of radiologists and scientists from the department. So welcome to everyone. Sarah, thank you so much.
Thank you very much for inviting me to talk. So as we say, I'll do about 20 minutes and then hand over to Gabby. But first of all, can I just check that you can see my screen and slides?
Yes, we can, thank you.
Brilliant, thank you very much. So my name's Sarah, I'm a second year PhD student at Professor Gilbert's, and today I'm going to talk through data pipelines and artificial intelligence research. I'm mainly talk about this from a breast perspective, but I've tried to make it as applicable to general radiology as well. But first of all, a huge thank you to everyone who's been involved in this research so far, to the people at the University of Cambridge Department of Radiology, especially Professor Gilbert for providing me with this opportunity, and also the medical physics team for their support throughout this project, as well as the team at the breast unit who provided a lot of input and guidance, and the team we've just started collaborating with in Norwich. And we've also got a fantastic database access committee, PPI team, contracts team, and Sue working with Sue, who works with MBSS as well, supporting us. So it's not just me alone, it's a huge networking team in itself. So thank you to everybody on this slide and anyone who's not on this slide who's helped as well. So as an overview of today's talk, we'll start with a bit of background of AI in radiology generally, and then look at its applications in breast imaging specifically, and then talk about how we've developed this mammographic database, and then come on to, at the end, testing commercial AI using this database and some examples of cases as well. But I really want to focus on these 3 questions, and these are the 3 questions I ask myself over and over again on a daily basis is, can we use AI in radiology now? And if you're from a breast screening background, can we use it in breast screening now? What additional evidence do we need before we can do this? And what would be the best way to apply AI into everyday radiological workflows or the National Health Service Breast Screening Programme? And so this is a starter slide, is a general image just pulled off of Google, but it shows you the sheer volume of companies now operating in the radiological AI space. So it's academic institutes, but it's also predominantly these private companies as well. And what we are starting to see is how can we really prove and show that these AI tools work within the NHS, and how can we even bring them into the NHS? And that's where we've seen this surge in guidance and the framework being built by the NHS over the past 3 years. So all of these documents on this slide have been published over the past 3 years and aim to kind of guide the safe adoption, similar to what we see in the pharmaceutical industry, of drug testing and monitoring and follow-up, as well as how we should regulate and what ethical standards as well need to be reached and taken into account, as well as how do we monitor these once we've actually taken it within the imaging department. And other guides as well from NHSX include the kind of procurement guide, the buyer's guide, what workforce would we need in place before we have the safe adoption of these AI algorithms into radiological workflows, and also about using data, what are the safeguards around this data that we use to test and monitor AI as well. And I've used the word AI a lot, but what do I actually mean? So AI is a broad umbrella term which covers machine learning, artificial neural networks, and deep learning, and can be broken down into these broad applications and narrow applications. And we focus specifically more on the narrow side of detection and diagnosis triaging that these tools provide us with. And why over the past few years do we see all those private companies being developed and now being used? It's because in around 2012, there was a big ImageNet study in Stanford, which happened a few years in a row. And one of those years, a team developed a network, or a deep learning network, which was shown to have a significant improvement in performance when it was applied to image recognition tasks. And that was on general day-to-day images like cats and dogs and cars. But actually, the idea was to bring those into medical imaging. And so now we see these in dermatology, endoscopy imaging, retinal imaging, and also radiological imaging. But how do you build an AI and what goes into that? Well, it's data. And we need to show the AI, they continuously learn as we show them more data. And it's broken down to these 3 stages of training, validation, and testing. And so at the training stage, you're showing it the data and maybe doing a supervised approach where you say this is cancer and this isn't cancer. At the validation stage, you're tuning the algorithm to find the operating point at which it works best. And at the testing stage, you're seeing, does that, well, I've trained it, I've set that operating point, how well does that perform? And this is if you've got one data set, then you can break it down into this 70-20-10 split that we typically see. And that's normally on internal data. So you have this one in-house data set to do this, to build these AI algorithms. And where we're moving to now, or what we aim to do, is then provide this external data set using 100% of the data to provide an external independent test. And again, I've used the word data a lot there. So what do I mean when I'm talking about data? Well, I mean imaging data, DICOM data, and the clinical metadata, which allows me to say if it's cancer or not cancer. And by external data, I mean data that wasn't used in that initial train, validate, and test steps. I mean data that's now the algorithm's never seen before, and maybe geographically different, a different country, from a different time point, from a different machine vendor. And then I would also need to know from that data what the ground truth of it was. So that's why I need the clinical metadata. So I can only say something's a cancer potentially if I have the histopathology. And it's a bit trickier when I have to say something's not a cancer, because there's lots of ways you could do this. One being if we have serial imaging, like we're doing breast screening, where we have follow-up time points, or I just do a routine follow-up at a certain time frame, or I use the radiologist report to provide my ground truth, my absolute outcome of that case. And then I talked about in validation setting the operating point, and how do we then test those algorithms which are built in that external test. Or I like to think about it as you set two thresholds, one being what the private company set as their AI threshold. And I'll just talk this through in a little bit more detail because these AUC curves were quite daunting to me at first, but I'll break it down into, so this is an AUC curve here on the top left. And what it shows is this area under the curve. So that's your area of performance metric. And then we have the specificity here on the x-axis and the sensitivity on the y-axis. Normally it's 1 minus specificity, but just for, I prefer if it's this way around, it's a bit easier to read. So down here, I'm really specific. I've made the algorithm really specific, but it's not very sensitive. So it's going to tell everybody they're normal, but it's not really going to pick up many cancers. And then up here, it's really sensitive. It's not very specific. So it's not really going to miss any cancers, but it's going to call back far too many people. And then up here, it's absolutely perfect. It's working. We don't have any worries at all, really. But if it's down here, it's as good as a flip of a coin. But realistically, we set the threshold somewhere which would be acceptable to performance. And that's where these test thresholds come in, or these benchmarks that we set. And we set these according to perhaps existing program standards or other literature. And in the breast screening program, we might use the 96% specificity based on the recall rate of 4% that's acceptable within the National Health Service breast screening program. And so what we want to see in the second threshold is at that operating point, does the algorithm exceed or reach the performance that I need it to say that it's safe enough to be used? And I can do that again on specificity or on sensitivity. And to generate this, another bit of terminology that's often used is 2x2 contingency tables. But what that means really is it's just the calculation of true positive, the generation of a table of the true positives, true negatives, and false positives. And these are two really nice studies which allow us to then apply this. So both tested on data sets from Sweden, both looking at can we apply AI to breast screening and mammography to work as an independent standalone tool. So working completely independent of the reader to say whether we could recall or not recall a case. And in the first study, it set the specificity threshold at how well the first reader was performing to see how well did the AI perform in terms of its sensitivity to compare. And we can see here it tested 3 different AI algorithms. And at that threshold of the first reader in a double reading system, the top performing AI did exceed that threshold, but the other 2 algorithms didn't. And then similarly, looking at this other study by Schaffer, which was based on the Big Dream study in 2016, which was quite a big study in the screening mammography AI application. It then set this threshold of sensitivity. So setting at the first reader's sensitivity, how well did the AI perform in terms of specificity compare, and we can then compare between the first reader and the AI. And at that operating point, again, we see the top performing algorithm reaching that performance, but the other 2 AI algorithms just falling short. So that's an application of a standalone AI performing a detection, so CAD-E, and diagnosis task. So CAD-E and CAD-X can be substituted in as the first reader, as we've just seen in those studies, or it can be used similar to traditional computer-aided detection, CAD, where it provides prompts, and we'll see an example of that later. But we also have triage algorithms which could bypass, which could say this is definitely normal, the readers don't need to see this, and these are possibly abnormal, can the readers have a look at these? And then we also have risk prediction tools as well, which could guide the use of supplemental imaging, which is another part of Professor Gilbert's large CRUK early detection grant, and seeing can we use the algorithms to triage women towards adaptive screen reading, towards adaptive screening. But how do we know, again, going back to those questions, how do we know if we should use AI now? Well, a lot of that, the literature in this field and across all of radiology is currently based on retrospective data sets. So what we really need is more prospective studies. We also see very few, those 2 examples some of the few examples of cross-comparison against different AI algorithms performed independently to the people who built the algorithms. And those are important to check for generalizability, to check it's going to hold up on different data. And also they're often performed on enriched data sets. So data sets which potentially aren't representative of the class imbalance we see in screening, where we see a large proportion of normals to cancer cases. And so what we're doing is building this large mammographic database, and we've taken, and this is an example of a test that we've recently performed using that database. And this is just using the data from Cambridge, but we, as we mentioned earlier, collaborating with Norwich to also expand this database to include their data as well. But this is our test just using Cambridge data from 10 years worth of screening, using just the processed mammograms across 4 machine vendors. And we took the interval cancers, which had the ground truth of histopathology, and normal cases who had a follow-up time point to say that they're normal at 2 screens. And we matched these by age and year. And then we also took 2 private commercial AI companies. And what we wanted to see is, can those private AI companies pick up interval cancers? So, for example, a woman comes for screening in 2011 and is recalled as normal, and then comes again in 2014, again 3 years later is recalled as normal and comes back for screening, and again is told they're normal here. And then between that screen and their next screen, they develop a cancer, and that's called an interval cancer. And what we wanted to see is, can the AI potentially pick up these cancers at an earlier time point on the previous screen? And we matched those cases to the normal cases screened on the same year. In this test, we can see that the AIs actually perform really similarly. And also when we combined their performance in red here, we see that there wasn't a significant improvement in performance. But setting those thresholds that we talked about earlier of the test, so for example, setting the threshold at 30% sensitivity to say, we expect that potentially 30% of the cancers could have been detected at the previous screen, we see a good specificity that would potentially be acceptable. And then setting the threshold of the test at a 90% specificity, we see that the AIs are able to pick up about 37% of these interval cancers at the earliest screen, which potentially could allow for an adapted reader approach where we take out one reader, and then the reader we've taken out is then just used to triage the 10% of additional cases that we're recalling. And then setting at that final threshold that I mentioned earlier of 96% specificity, we see a 23% of the cancers could have been picked up on the screening mammogram by the AI. And so that's one, again, an example of using computer-aided detection and diagnosis artificial intelligence to substitute a reader, and for this task to substitute to improve interval cancer detection rates. But what I'd like to do now, just to finish before I hand over to Gabby, is just show some example cases of using CAD in a more traditional method like the previous CAD studies. So keeping the 2 readers and then seeing how they interact with the CAD. So what I'd like you to do is, if you've got a piece of paper and a pen, just grab those. And then what I'm going to do is show you some screening mammograms to start with. And then I'm going to show you what the CAD thinks it sees, and then see if that changes your opinion on the case. And then I'll show you the outcome. And we've got 4 of these cases. And as I mentioned earlier, we've got these thresholds to consider. So in this test, the AI is saying something's positive if the marker is above 50%. And we'll work through the first one together. So this is a woman who's come for their screening mammogram. So we've got their 4 views, their CC and their MLO views. And I'd like you just to look at this. The average screen time, I think, is about 30 seconds to look at a mammogram. So I'll give you a couple of seconds to look at it. Jot down if you think this is abnormal or normal. Would you recall or not recall this case?
Sarah, do you want to put your slides on full screen? Because that might make it easier for people to see.
Oh, of course. Yeah, sure.
Yeah, thanks.
Sure. I'll just, let me just put this up here and stop sharing. Share. And then is that any better there?
That's brilliant.
Perfect. Okay, so I'll give you a couple of seconds just to look at this case. Okay, and as I say, we'll work through the first one together. And then same screening mammogram, but we've run a CAD model over this, and it's shown us, it's popped up this prompt and this prompt here, but this prompt's at 68%, so it's above that AI threshold that I mentioned. So this is saying that this is a positive prompt. Would that change your decision? Okay. And then this is a different AI, but similarly setting it at 50%. Would that change your decision? And I'll do the big reveal. So the outcome, so this was a true positive case. So this was an interval cancer, but I'll walk it through. So on the screening mammogram, so this woman, say for example, came in 2011, and they were recalled as normal. So they were told to continue with normal screening, and nothing was detected. When we feed that same screening mammogram from 2011 back through the AI system, the AI potentially picks up that there was an abnormality at that time point that wasn't detected. And what happened to this woman came back 549 days later to find a cancer on her left side. So going back to our question at the beginning is, could we pick up cancers at an early stage? But as you might have noticed, this is a very challenging task when reading screening mammograms. It's often not obvious if there's a cancer or not. But also, as you might have found when you did that walkthrough, it's difficult to know whether the CAD would change your decision or not. So we'll do 3 more examples. And so this is the first one. Again, I'll give you a couple of minutes just to look at this. Okay.
Very tricky, Sarah.
They're very tricky, and this also caveat, this isn't a high resolution monitor, and also you don't have the previous time points, so completely understand. And also these are meant to be tricky. It is interval cancers are cancers that are the hardest test you can do. So, so this is with the CAD prompts. Would that have changed your decision? And then the big reveal. So this was a false positive case. So what I mean by that is this was a normal case on the screen, and at a second time point, 3 years later, this woman was reported as normal again and was a normal case as our ground truth stands. However, when fed through the CAD pops up with a really high likelihood of there being a cancer there. And so exceeds that threshold of saying it's positive. So both AI tools, when we ran this case through, said that this was a positive case, which the readers correctly said was normal. And we'll just do the last 2. Just give you a few seconds and then show you the CAD prompt. So again, remember that threshold is 50%. So this is less than that threshold. So the CAD's not saying this one's positive. Okay, and then the big reveal. So this case was a false negative. So this woman came for screening, was said to be routinely recalled, so said to be normal. And then when we fed that same case, same screening time point through the CAD, that also said this is not a normal case. However, this woman came back 1,101 days later to be found to have a cancer on their right side. And as we can see here, this is because this CAD mark didn't exceed that threshold that we've set it at. So if we set a different threshold, potentially that marker would have exceeded that threshold, but it's a complete trade-off between sensitivity and specificity, as we saw on those curves at the beginning. And last case, so again, give you a couple of seconds. And then give you the CAD prompt. So again, this one's not positive because it's not above 50%. And then the big reveal. So this was a true negative case. So this was called normal by the radiologists at their screen, and feeding the same screen through the CAD was also called normal at that threshold that we set by the AI. And so these are just, again, those 4 metrics that we use over and over again in this research of true negative, true positive, false negative, false positive, and just some examples of those. So going back to our questions at the beginning, can we use AI in radiology and breast screening now? Well, I'll leave that up to you to decide, and up to you to decide as well about this next question of what additional evidence would you want to see? And the last question of what would be the best way to apply AI into everyday radiological workflows or the National Health Service breast screening programme. And I've shown you a couple of examples, but it'd be interesting to see if anybody had any creative other thoughts of how we could apply this technology. So huge thank you for everyone for listening. Here are some references in my email if anyone has any other questions. And I will hand over to Dr. Baxter.
Thanks, Sarah. That was absolutely terrific. Thank you so much. Those are very tough cases. That'll put everybody off becoming a screening radiologist. But as Sarah points out, there were interval cancer cases. And arguably the case where you showed us the one at kind of almost the 3-year mark, where the interval cancer was a grade 1 and only 5 millimeters in size, it arguably might not have been there on the screening mammogram. So it might actually have been not a false negative, but the algorithm might have been completely wrong. I mean, there was nothing there to detect,
Exactly.
Arguably in that case. Yeah.
Yeah, completely.
And so any questions for Sarah from anyone? I can't see people's hands. Any questions you want to shout out or put a question in the chat?
It's Tilak here.
Oh, hi, Tilak.
Hi. Thank you very much, Sarah. I missed the beginning of your talk, but I caught the right bit, which is the challenge. And what I'd be interested to know, you're asking what other evidence we'd like to see. And if I were presented with, I thought a case was normal, and then an AI that we've implemented said 99% sure that it's positive, there's a 1% chance that I'm going to stick to my guns. I mean, I'm basically going to go with that AI because 99% seems almost, definite. And surely it's safer to have the patient undergo a biopsy and all the, potentially resulting harm from that than to stick my neck out and go against the AI, which has given me an almost 100% probability of having detected something. So what I'd like to see is how biased do we get? We know obviously from previous CAD experience that radiologists are biased, and the data from the state showing that they perform a bit worse. So how is AI going to do that to us now?
Good question.
Yeah,
not asking for an answer.
No, I think it's a brilliant question. I think that's why we completely need prospective studies to understand that. And I think also knowing those thresholds that I talked about before of what are you operating within to understand what your AI is saying is positive and negative, what's that based on, I think also will have an influence.
Excellent. If there's no other questions or anyone else want to comment or say anything, can't really see everyone. Gallery, here's the gallery. Okay, well, Sarah, that was terrific. Thank you so much. And you're doing a brilliant piece of work. We're just so enjoying working with you, and lots of people helping Sarah, as she listed, Richard Black doing a sterling job, and Nick Payne really helping, Martin Graves, also contributing to that work. So really fantastic. And of course, all the team in the breast unit as well, really helping with the interval cancer database. So that's very much appreciated. So Gabby, do you want to share your screen now?
Hi. Yeah, let me do that. So yeah, that was a great intro by Sarah. I feel like she's laid a lot of the groundwork for what I guess is a slightly more niche and more nuts and bolts project and looking at AI. Okay. Can everyone see and hear me? Okay.
Yes, thank you.
Okay, so yeah, I'll be talking today about a piece of work that I've been doing where we're looking at trying to predict pathological complete response to chemotherapy in breast cancer. and the various machine learning approaches that we've tried, namely a radiomics-based approach and also a deep learning-based approach. So firstly, neoadjuvant chemotherapy is often used in the treatment of breast cancer with its primary aim to decrease the size of large tumors before surgery. This allows for more conservative surgery. And the ideal outcome of this is pathological complete response, which has a few different definitions, but the main definition is often the absence of residual invasive carcinoma in the breast or the lymph nodes. And this has been shown to be an indicator of long-term survival. And so MRI has been shown that it's the most accurate modality to assess response to chemotherapy throughout treatment. So women will often be imaged at the beginning of their treatment before they've received treatment as baseline scan. They'll be imaged at a mid-treatment time point, usually after 3 or 4 cycles of chemotherapy. And then they'll be imaged again at the end of their treatment. And in some of our research studies, we also image women quite early on in their treatment after their first cycle of chemotherapy to look at kind of early responses and monitor early changes and things like that. And so ideally what we would want to be able to do is an early prediction of response, or really realistically an early prediction of not response. And this would mean that we could avoid unnecessary toxicity by stopping treatments that's ineffective. And this has been shown that MRI has a much higher accuracy than other modalities in early predicting response to chemotherapy. So an interesting question that I wanted to ask was, is it possible to predict pathological complete response before women would even start her chemotherapy, and specifically using MRI? And if so, then what features of that MRI are going to be predictive of whether that cancer will respond to chemotherapy? And this is where the kind of AI concept comes in, is that this is absolutely no shade to radiologists, but I think it'd be quite difficult to look at a baseline MRI and say with kind of a high accuracy that this cancer will respond or not respond to chemotherapy. There are things you can look for, obviously, but what's interesting from an AI perspective is that when you bring in a computer algorithm or some kind of deep learning technique, you might be able to kind of tease out details from these MRIs that the human eye just isn't possible to perceive. And so, yeah, as Sarah described earlier, there's kind of these layers of AI, machine learning and deep learning. And so the kind of broad umbrella term of AI, where we're talking about using computers to perform tasks that usually require human intelligence, is kind of big umbrella catch-all. And so in this case, the kind of task at hand is to predict whether, well, specifically to take an image and decide based on that image whether that patient will respond to chemotherapy or not. So kind of almost a subset of that machine learning specifically refers to training computers, training an algorithm to find patterns in data to make a decision or a classification. So in this case, whether that be the MRI images themselves or MRI-derived features or radiomics features. And then an even more specific subset of that, deep learning, refers to the use of kind of multiple algorithms working in a network that extract more complex features from input data. And so the idea here is, can we train a computer essentially to look at a baseline MRI image and using either features that we've engineered or features that the network itself has engineered, can we predict response? And so from a kind of more commonly used MRI protocol, there's a number of in vivo biomarkers that have been used to assess response to chemotherapy. So kind of obviously tumor size is very commonly looked at in monitoring response and changes in tumor size. Things like functional tumor volume, which incorporate kind of enhancement to kind of look at what actual size of the tumor is kind of more active. Particularly in this study, I'll be looking at dynamic contrast enhanced MRI, which tells us information about tumor vascularity. You can look at this qualitatively, quantitatively. In our research MRI protocols, we have the ability to do pharmacokinetic modeling, so we can fit parameters which describe the transfer between the intra and extravascular spaces. And then we also have diffusion weighted imaging, which gives us a biomarker of cellularity. So all these kind of, various parameters that we can derive from MRI that will be able to enable us to assess whether a cancer is responding to therapy, and will provide us with information about the tumor microenvironment itself. So these parameters, these features are they're describing real biological and physiological processes. And those have been shown time and time again to be useful in assessing response. And in particular, for this work, I was looking at dynamic contrast enhanced MRI. We have a very good research DC protocol. It's a slightly higher resolution than our normal clinical protocol, and it has a very high temporal resolution that allows us to do that pharmacokinetic modeling. But for the purposes of this work, I kind of took the temporal resolution down to what it would be in a clinical protocol. So that there's kind of this one image required before the contrast injection. And then there were 5 time points post the contrast injection with a temporal resolution of about 90 seconds. And creating subtraction volumes where you subtract the pre-contrast image from the post-contrast image will give you kind of a 3D volume image that has some temporal and some enhancement information. And those are the images that I've used for the rest of this work. So as well as kind of standard MRI parameters that you can derive, there's a lot of interest in radiomics-based analysis at the moment. And I would argue that radiomics, kind of more broadly, I would define as extracting features from radiological imaging. And I think what people kind of tend to be referring to is texture features, which are a type of feature that you can use to kind of quantify heterogeneity, specifically usually within the region of interest of a tumor itself. And if you think of an image as it is just a big grid of numbers, and you can apply these mathematical operations, which mean you can quantify spatial relationships between these numbers, so pixel values or gray values, however you want to refer to them. And we do this specifically inside the tumor to kind of quantify intratumoral heterogeneity. And this is a kind of feature that, with the human eye, you can kind of look at a tumor and say, oh, it's kind of looks heterogeneous or whatever. But with radiomics-based analysis, you can extract, huge numbers of these types of features that hopefully provide us with more information about a cancer, and hopefully will help us predict response to chemotherapy. And so some of these features that are commonly extracted are things like gray level co-occurrence features, which look at kind of pixel values and how often they kind of occur next to each other in certain dimensions in the image. You have run length features, which look at like long runs of similar gray level values. You have size zone features, which look at clusters of similar pixel values. And then you have things like the neighboring gray tone difference matrix, which looks at kind of neighborhoods of pixel values. And all of these types of features, you can extract, hundreds of them per cancer. And the kind of idea here is that, you have these hundreds of features, you have lots of cases. Can we then train a machine learning model to decide which of these features, number one, which of these features are actually predictive of, are helping us predict response, but also can we just accurately predict response? Like if we can do that without knowing what these features mean biologically, then is that good enough? I think compared to kind of, more established MRI biomarkers, these are very abstract. They don't necessarily have a kind of underlying meaning that you can ascribe to them. So how do we use, DC MRI, and how do we use these various features that we can derive from DC MRI to predict response? And so this is the kind of general overview of what I've been doing. So it's kind of two different approaches, which are quite different. So radiomics-based analysis, you extract a number of features, you do some form of feature selection to kind of reduce these huge hundreds of features. And then you train a machine learning classifier to predict whether a new patient or you put in a new image to decide whether that will respond to chemotherapy. And then kind of the separate branch of that is a deep learning approach. So using here a convolutional neural network where realistically all you have to do is kind of stick an image in at the beginning and the network will take care of the rest. So it's kind of about, are we engineering these features from the MRIs, or can we just, say, here's a general area where cancer is, and then we have a neural network which does the rest, I guess. So in terms of the actual radiomics feature extraction, I've been using this PyRadiomics package, which is quite well used at the moment as a Python package. And one of the kind of big problems with radiomics analysis at the moment is the kind of lack of standardization of feature extraction, even feature definition. So kind of mathematical operations that you perform that will calculate these features, and the way in which images are normalized or standardized. And so at the moment, there's this, it's a quantitative biomarker standardization initiative. So it's a kind of set of guidelines that will help guide through a radiomics-based analysis, and kind of it's a big consortium of various research groups who've decided that kind of these are the guidelines of how we should go about doing radiomics-based work. And as far as I know, this package kind of abides by those guidelines quite well. And so you can extract a whole number of different features from these MRIs. So even just, first order histogram features. So looking at the histogram of the gray levels within a tumor. And so you can look at the mean, the max, kind of skewness of the histogram. And these are kind of more straightforward, they're relating to, in the case that I've used, a subtraction dynamic contrast enhanced MRI image that would relate more kind of straightforwardly to something like enhancement and therefore vascularity. Then you also have things like shape features, which, the package is able to extract three-dimensional features or two-dimensional features. So looking at tumor volumes, or even interestingly, sphericity. This has actually been shown, a study that came out about this last year, the year before, where they actually showed that sphericity, so how round a cancer is actually a predictive marker of response to chemotherapy. And you can also get, so tumor size you can measure quite easily when you're reading your standard clinical treatment response MRIs, but you can also do these measurements on various axis lengths, so kind of in 3 dimensions, depending on how you measure that. There's different or different ratios of those axis lengths. So there's kind of a very interesting number of shape features that you can look at. As well as all the texture features that I just described. And so including all that kind of temporal information from a whole dynamic series of images, you can extract, I've gone for 409 features per cancer. And so the kind of idea is that you want to do some kind of feature reduction before you start training a machine learning model. You want to remove redundancy, you want to kind of take out any information that's not going to help your prediction. And there are ways to do this, just to rattle through quickly. You can do like a correlation-based analysis where you look at various, you find correlations between all of the features, and you set kind of threshold of, say, Spearman's rank correlation coefficient is over 0.9, which means that these two features are really highly correlated. You're not getting any new information by including one or the other. And so you can take the feature that is less able to predict response when used on its own, and just get rid of that one. So you're not gaining any new information from that. And then I also did something called recursive feature elimination, which is a machine learning based technique which essentially ranks features in terms of how helpful they are, and then just like boots out the ones that aren't that helpful. And in that way you can go from 409 radiomics features down to just 14, which will hopefully improve the way in which your machine learning model can be trained and can do predictions. And in this case, these 14 features that were left behind were kind of non-redundant ones. Included some shape features, some histogram features, and then a bunch of texture features. The texture features in particular, kind of shape features you can ascribe meaning to. You can tell how spherical a tumor is, or I think maximum 2D diameter column is to do with, it's kind of an axis measurement based on if you put your image in the coronal plane or something like that. So it's kind of, one of these interesting shape measurements. But these texture features, you don't really, you could try and look at different images with high and low, I don't know, gray level co-occurrence matrix features and decide what that might mean, but realistically, they're just kind of additional higher order information that the human eye or a radiologist might not be able to pick out. And then, so I took these 14 features and trained a machine learning classification model. So I've used ElasticNet here, which is just a logistic regression model. And that model will be able to predict response or non-response from an image. So in contrast to that, it's quite an involved pipeline in terms of radiomics. There's a lot of kind of hands-on selection of the features and feature reduction techniques and things like that. So I wanted to try a more like a deep learning approach, which is a lot more hands-off. And for this, I've used a VGG net, which is it's a convolutional neural network that was designed for the ImageNet challenge, as Sarah described. And so basically, this was, the ImageNet's this big database of 14 million freely available images. And the ImageNet challenge invited people to design, networks and architectures that would be able to classify these images with a higher accuracy than ever before. And VGGNet is kind of one of the big networks that came out of that project. And that just means one of the benefits of being able to use a network like this is, well, obviously it's been shown to be good, but you can also, you can use pre-training. So that means that you can take your network and pre-train it using ImageNet. And that means that it's already been sensitized to how to classify images, how to do an image classification task. And as Sarah said, in that case, it might be the ImageNet images, saying cat or dog or car or tree or whatnot. But this will improve the performance of the model because it already knows how to do image classification. And so a convolutional neural network, I would say, is probably the most common type of deep learning network that you'll see in medical image classification, I would say. And that these types of networks are characterized by the use of these convolutional layers. And essentially what that means is that you have your input data, or your input image in this case, and there are these kernels that are applied to your input images, which extract these feature maps. And so there's different types of kernels. So these are just small matrices that are applied to an input, because a convolution is just mathematical functions, right? And these will extract features from kind of a bigger image. And this kernel in particular, I think, is an edge detection kernel. There are other kernels that you would use for things like filtering or blurring or sharpening, and it's basically pulling out higher order information from your input image. And by using layers of these convolutions, you're generating feature maps from feature maps, and then feature maps from those feature maps, so that your features are progressively more complex, I guess. And as well as that, you have these max pooling layers, which just take the maximum value from these feature maps of regular intervals. And then the later stages of your network are fully connected layers. And what these do is they take these features that have been extracted from your various layers, and they map them to the outputs of your network. And so in this case, it's just, we want to predict whether an image as a patient who will respond to chemotherapy or who won't. And it's the training of the network with all the data that means that the relationships between these feature maps and all these extracted features and your outputs, it's training the models that helps the network decide how important these different feature maps and how important these different features are that contribute to the overall prediction of or overall classification. And the final layer is just a softmax layer, which takes your network features and then does a function and turns them into kind of a decimal probability of whether that input image will be a responder or non-responder. And so, yeah, some actual results. I did this based on 152 patients from one of our studies, and there were 60 of them who achieved pathological complete response and 92 who didn't. And very important in any machine learning work is to split your data. Sarah said, into, you've got training and test data. You want to be able to train your model with a large proportion of your data, but you also want to hold out some unseen data to test how your model will generalize or how it will handle new cases. And as we can see, our radiomics-based work performed pretty well in the training set, but pretty badly in the test set. And so that might indicate that there's a lack of generalizability, so it might not be able to handle new unseen data very well. In terms of, machine learning concept, this means that it's, potentially learning patterns in the training data too well, and then it's not able to learn from new data to make predictions on new data. Whereas our deep learning approach with the VGGNet performed really well in the training set and then also really well in the test set. So it's able to generalize better than the radiomics model. So this is kind of higher accuracy of prediction. And so, yeah, really promising results from that deep learning approach. But I think what is interesting about the radiomics-based work is that you can, by going through that filtering process of, calculating loads of features and then reducing the features and making these predictions, you can actually kind of pick out which of those features are the ones that are contributing to your decision making or to your prediction in your model. And I think that is a valuable thing to be able to do. In terms of deep learning, that's a little bit more difficult, but I think my next steps in this work is looking at what actual information a convolutional neural network is using. And you can do this by generating these saliency maps. There's this really cool study who did this recently, and they were looking at predicting similar task of predicting response from different DC MRI images, and they were able to kind of map back that feature information through their network to their input images, and create these maps of kind of hotspots of what the network was looking at and what it was considering important in its prediction. And interestingly, they found that it was this kind of peritumoral information, or kind of the edges of the cancers, kind of enhancement in interesting places that was actually contributing to the accuracy of the prediction of the model. And so that essentially might suggest that a radiomics-based approach that looks specifically at intratumoral information, just within a region of interest, is not enough to predict chemotherapy response. So that's an interesting next step, I think, that I'm going to be looking at, is looking at these saliency maps. So this is a really huge ongoing piece of work, but loads of people have helped over the years that I've been doing this now, from the machine learning people to the radiologists to all the MRI physics support. So big thank you to everyone that's helped with this. And yeah, so my email's there if anyone has any questions they'd like to